Thank you for joining us for today's webinar, The Use of EMDR Therapy in the Treatment of Addiction. My name is Marla Kaufman, and I'm the Senior Communication and Health Promotion Associate at IRETA. I'll be moderating our webinar today. As you log on, I am going to launch a survey, so please fill that out at your convenience. I would like to go over some quick housekeeping items on how to use the WebEx technology and how to access continuing education credits. First, we would like to encourage you all to participate in today's webinar in a few ways. If you have questions for our presenter or are experiencing any technical issues, please use either the chat function or the Q&A panel to communicate your questions. Our presenter, Jeanne Meyer, will take questions throughout the webinar. Feel free to submit your questions through the chat box at any time. This webinar is approved for 1.5 PCB and/or NADAC credits, which are free. A certificate of attendance will also be available to download from your MyIRETA account 48 hours after the webinar. Please take note that it will take up to 48 hours for your CEUs and certificate to be available in your MyIRETA profile because we have to cross-check attendance records with WebEx following the webinar. After the webinar, you will receive a follow-up email. This email will include a link to an evaluation form for the webinar, as well as more information on how to access your certificate of attendance and continuing education credits. We may send you an additional email to remind you of the evaluation. I would now like to introduce today's presenter. Jeanne Meyer, LMHC, LPC, MAC, has over 20 years of experience working with co-occurring substance abuse and mental health problems. Her experience includes therapist, clinical supervisor, assistant program manager of the co-occurring treatment program at Lifeline Connections, presenting workshops, trainings, and webinars. She has worked in outpatient co-occurring treatment programs, chemical dependency agencies, and private practice. She was trained in EMDR therapy in 1996, is a certified EMDR therapist and approved EMDR consultant. She currently has a private practice that specializes in addiction and trauma recovery. She is a clinical supervisor for Oregon and Washington and a consultant for EMDR therapists. Okay, Jeanne, I will hand things over to you. Have you are you able to see the responses
I am not.
to the survey? All right, let me see.
Do we need to do something special here?
How about now? Can you see that?
No.
All right, you might not be able to see it because you're sharing your screen, but I can summarize. So it looks like most people that are joining us are counselors, therapists, social workers, or case managers. A few have marked other. Field represented, we have about half are coming from the mental health field, 33% from addiction treatment, 6% from physical health, and 11% from education. Experience with EMDR therapy, 16% said none, 26% said I've heard of it, 5% say I've personally had EMDR therapy, 15% say I know someone who had EMDR therapy, and 30% say I have completed EMDR basic training. And then 10% say I am an SUD specialist without using EMDR therapy. And then for what are folks hoping to get out of today's presentation, I'll just read through some of these answers. We have learn how to use EMDR for addiction treatment, more information, how to use the techniques, new knowledge and resources, information about EMDR and addiction, more specifics on EMDR and current efficacy, a better understanding of EMDR's research-supported application and whether it makes sense to invest in formal training for my professional practice, better understanding of this care to help patients with understanding option for treatment, to gain an understanding of how to apply this to my participants on my caseload, a basic understanding, learning how to expand my use of EMDR, and applying my new EMDR skills to my field of practice.
Okay.
All right, so I am going to deactivate that survey now and let you get started, Jeanne.
Okay. Let's see. So here's my contact information. Hi, everybody. It's morning here on the West Coast. I am from Vancouver, Washington. So we've had a little thunderstorm and the air is clearing. So here we go. Okay, so here are the learning objectives: to have an understanding of the adaptive information processing model of EMDR therapy. So this is the foundation of how EMDR therapy works. And it's a really different way of looking at therapy and what's happening with clients. So we're looking at the functions of the brain with traumatic memories, and also with how addiction kind of works with the memory networks. Be able to identify specific goals of treatment based on changes of stages of change and stabilization skills, and identify 2 EMDR therapy protocols for reducing acute symptoms of craving and euphoric recall. So this presentation is a general overview of addiction treatment and EMDR therapy. You will not learn EMDR therapy, nor will you learn how to use the specialized addiction protocols. So those are specific trainings. The basic training for EMDR therapy is 6 days, and needs to be put on by an approved EMDR trainer. The specialized addiction protocols, there's absolutely no time to teach those, so I'm just going to go over kind of what they are. And so there's been this debate about what came first, trauma or addiction. And the bottom line is sometimes we know and sometimes we don't. We will fail the client if we treat the underlying causes without treating the addiction. Conversely, if we fail a client if we treat the addiction and not the pain that's tied to it. All right, so I want to give you an example of somebody who I do not believe had any trauma, but definitely has symptoms of enjoying being altered. So I was at a meeting, and somebody had brought their infant, probably about 6 months old, and she was laughing and happy and interacting with people. And she was sitting on the table, and she started throwing her head back and forth and back and forth and back and forth to make herself dizzy. And then she would kind of bob a little bit. And then when she wasn't dizzy anymore, she did it again. And that happened 4 or 5 times. So this baby had not had any trauma, but she really enjoyed feeling altered. So that's an example, I believe, of somebody who doesn't have trauma but has addiction. There's also a difference between people who, especially with substances, if somebody who uses for the first time, whether it's alcohol or anything else, and they feel great, like the first time they get altered when the drugs are in their system, they just are, just feel wonderful. and the people who will use for the first time and hate it because they feel out of control. So there's like this biological difference between people who have addiction and people who don't, that I think is completely separate from trauma. So the NA basic text talks about having fear. So fear is definitely associated with trauma. So for my purposes, addiction is a primary brain disease characterized by a compulsion to use substances or engage in behavior to alter one's senses, despite knowledge and experience of negative consequences, and I think this is one of the most important things, violating one's own values. So in treating substance abuse and trauma, we still end up treating the disorder separately at different times and places with different treatment teams and therapists. Then we have the expectation that the client will be able to integrate the information, skills, and recovery process themselves. So what could possibly go wrong with that? So we as therapists are not able to integrate the substance abuse and the trauma therapy at the same time, but we're expecting the client to be able to. So then clients end up only being treated for part of the problem. The providers may not agree on treatment and they do not coordinate with each other. There's no comprehensive treatment plan, no relapse prevention plan, no recovery plan. And then the clients will relapse, whether with trauma symptoms or with their addictive behavior. So if you can imagine, here you are a client and you've got this horrible history of addiction and you've tried and tried and tried to stop. Every time you stop, you start having nightmares and you can't sleep, and these memories keep popping up that you don't want at all. And the only thing that helps is getting loaded. So you go into treatment, therapy, trying to get better, and you get sent to different clinics to deal with substance abuse over here and the trauma over here. And then try to figure out how to put that all together. So you feel like nobody understands. Nobody understands what's going on with you, and that there's something wrong with you, that treatment is not working. And the treatment professionals may also blame you for relapsing. So think about when you were learning how to drive. So you had somebody who was teaching you, who knew the whole car and all the components of and the skills that you have to have in order to drive. So what we're doing is we're saying, hey, we're going to teach you how to drive. Here's the steering specialist who's going to show you how to steer. And then you're going to go to an acceleration specialist who's going to show you how to use the brake and the accelerator and how fast to go and things like that. And then you on your own are going to try to figure out how to put that together. Okay, so the best strategy is to do both at the same time. So having addiction itself is traumatic. So you feel out of control. You do things that are not okay with you or anybody around you. And that in itself is traumatic, plus all the things that you experience. So trauma interferes with recovery from addiction, and addiction interferes with recovery from trauma. Okay, so just an example of the traumas that people with addiction will go through. So there'll be family conflicts. Sometimes they lose custody of the child or children. There'll be financial problems, maybe bankruptcy, violence, either witnessing it or experiencing it, or perpetrating it, rage, betrayal, abuse, incarceration, job loss, homelessness, and the horror of violating your own values. So it's a type of moral injury that gets in the way of addiction recovery. What kind of person am I that I did all these things? So that is a major thing that we need to address in treatment, is the shame of doing things that are not okay with you. Okay, so let's look at what the similarities are between addiction and PTSD. So some of these symptoms are the same, like dissociation, tuning out, being distracted, inconsiderate, feeling alienated and alone, detached or estranged, anxiety, fear, sensitivity to stress, emotional ability, so crying or yelling, or constriction, where you don't show much in the way of emotions, or there are faint smiles or shrugs when people are talking to you, difficulty with concentration and thinking, sleep disturbance, and triggers, cognitive distortions, so thinking errors or negative cognitions, depending on which school of thought we're thinking about, blaming self or others, minimizing, intellectualizing, among other things. Persistent negative feelings, no or little interest in activities, anhedonia, so not able to feel the positive emotions, irritability, and self-destructive behavior. So these triggers consist of the same type of stimuli for both trauma and addiction. So we got sights, sounds, smells, physical sensations. So any of the senses can be triggers. Like the time of year or day, birthdays, events, holidays, and people, places, and things. Okay, so I want to open it up for questions and see if there's anything that you want to have answered right now. So I'm going to have this question period. There'll be another one a little bit later.
So I see that Susan asked, is there a way we can get a copy of the PowerPoint? Yes, Susan, we will be providing the copy or a PDF version of the slides to participants, and it will also be available on the website with the recording. Does anybody else have any other questions up to this point? Please feel free to submit them in the chat box. Okay, Jean, I don't see any questions coming in, so please continue to submit those throughout the webinar as you have them.
Okay, so let's talk about treatment with EMDR therapy. So for people who are not familiar with EMDR therapy, there are 8 phases. So this is not a technique, it's a full therapy. It's not just doing like eye movements or just the bilateral stimulation. There's a lot that has to happen before we get to that. And so the first 2 phases of EMDR therapy are what you normally do anyway. So the only difference is that we're looking at from kind of a brain trauma memory network perspective. So when we're doing history and treatment, we're looking at kind of what kind of traumas people are talking about and making note of that. And we're also noting, what kind of addictive history they have and, what their current addiction is. So how much, how often, how long. So we're looking at all of those things in the history and treatment plan. Then in preparation, this is where most of the traditional addiction therapy would come in. Plus, we would add kind of understanding what EMDR therapy is, how it looks, kind of what the mechanics are of it. And this is also a very important piece of stabilization that absolutely has to happen before we're doing any kind of processing. So with EMDR therapy, phases 3 and 4 are what most people think of. 3 and 4, 3, we're bringing up whatever that memory network is. So we're basically creating a trigger, followed immediately by desensitization. So we're not going to trigger somebody and then send them out the door. We're going to trigger somebody so that we can start the bilateral stimulation. So this is the part that people think is pretty weird or magic. And desensitization or the BLS can be either eye movements or it can be auditory. So sometimes people will have headphones and there'll be like a tone that goes left, right, left, right, left, right. And or some type of tactile. So sometimes if somebody's in person with a client, they will like tap on their knees, or especially if we're doing telehealth, then this is the butterfly hug, and that works really well. So there's just tapping back and forth and back and forth. And so after we've triggered the memory network, then we do sets of bilateral stimulation, and we check in periodically and see if there's anything that's changing between sets. So we are trusting that the brain wants to heal. And so at this point, we as therapists are along for the ride. So we trigger it, we start the bilateral stimulation, we check and see whether anything is changing. So is the brain processing? And then we do another set and we check in again, and then we do another set. So generally speaking, what happens is that the emotions and the distress get more and more and more and more intense. and then it resolves. And when it resolves, people's attitudes and belief systems and emotions change, and I don't actually know of a situation in my practice anyway where that change has gone away. And I've checked with clients like years after we've done some processing of a specific trigger. So I go back and say, okay, let's bring up that trigger, and it doesn't trigger anything anymore. It's just a memory. So this is the kind of weird part of EMDR therapy, is the desensitization. And then in phase 5, we are looking to see if there's anything left that didn't get processed. So we see a big movement in phase 4. And then in phase 5, we're like, okay, so now when you think about the trigger and I say this positive belief, what happens? And then if there's still a discrepancy, the cognitive dissonance, then we'll continue using the bilateral stimulation until that resolves. Then we go back, after that's resolved, then we go back and do a body scan. So we're checking to see if there's anything that's still stored in the body that's associated with the memory network. And we do the same thing. So if there's some kind of body sensation, whether it makes any sense to us or not, like my ear is twitching, then we do more bilateral stimulation. And believe it or not, the physical sensations change. And then phase 5 or phase 7 is closure, like you would do in any session, make sure that the client is okay to leave. And then at the beginning of the next session, we're checking in to see if there's been any change or repercussions from the processing. And then we're checking kind of our measurements of how distressing the trigger is and how true the positive belief is. So if any of that is still disturbing, then we go back to phase 4 and do some more bilateral stimulation. So it's kind of a general overview. Now, this is all based on the adaptive information processing model. Basically, we know that the body has a strong healing mechanism. So if you cut yourself and it bleeds, then the body just goes into, let's, heal this. And there'll be, inflammation, there'll be blood clotting, there'll be, white blood cells that are released, and the body starts healing. If we need to go to a doctor for stitches or something like that, the medical professionals are not healing the body. They're setting up the conditions so that the body can heal itself. So they may clean out the wound, they may put stitches in there, they probably put antibiotic on there and bandage it up, and then we expect that the body is going to heal the wound. Well, the brain does the same thing. If it has the right conditions, then those memory networks, those intrusive memories, flashbacks, panic attacks, nightmares, will heal. But we have to set up the conditions so that it can. And for some reason, bilateral stimulation is one of the conditions that helps it heal. So we know that neurons kind of connect with each other, and that part of what's connected with, let's just talk about a trauma incident, is that what you've seen stands out and gets seared into your memory. The sounds get seared in, taste, touch, smell, and then we'll have an interpretation about what happened, and we'll have emotions about it. You know, the weather, anything gets stored in that neural map. So part of course, why it gets stored is that it's survival. We don't ever want to go through this again. So the brain is like, oh, okay, well, I don't know what's caused this or how to keep it from happening again. So I'm storing every single piece of information so that when any of those things happen again, I can be ready. So it goes into survival mode. Okay, so one of the things is that these are dancing neurons. We don't know what dendrites are connected to what dendrites. We don't know. And so when we're doing EMDR therapy, we may start with kind of activating this neural memory experience, and it goes, oops, it goes through the neuron and then attaches to another neuron, and we don't know what the connections are. They just happen. So if you think about free associations, like your mind just goes where it goes, and so we don't have any control over that. So one of the things with EMDR therapy is that when we start the processing with the bilateral stimulation, we have to stay out of the way. So we set it up so that we start here, for example, and then the bilateral stimulation allows the brain to move through that memory network and unlock those kind of hardwired connections. So what will happen, of course, is that when you're triggered, you feel like you're in that situation again, like you're reliving it. And so what will happen in the reprocessing is that you don't relive it anymore. You remember it, so it doesn't impact memories themselves, but you don't feel it anymore. It doesn't feel like you're reliving it. It's just a bad memory. So this is the principle that we're using with EMDR therapy to let the brain heal from traumatic experiences. So in the same way, addiction triggers are very often sensory and emotional, and there are things that are tied in that we don't know. So it's much more predictable that if somebody has alcohol as their drug of choice, then if they go into a bar and they smell it and they see people drinking, that's going to be a trigger. So that's much more predictable. We've got a better idea of what kind of triggers there are with trauma, but with both, we don't know for sure what's going to be a trigger and what isn't. Why? We don't know. We can guess. Okay, so speaking to the EMDR therapist, we have to consider the stage of change. So clients don't come in going, hey, I want to quit using, I'll do anything it takes, and I'm ready for EMDR and I can face my trauma. It doesn't work that way. And so there are these stages of change, starting with pre-contemplation, which is, I don't have a problem, leave me alone. Preparation, I have a problem, sometimes, but they still think of their addictive behavior as the solution. So they may be, starting to think about, okay, I am going to set a quit date, or I'm going to only drink beer, that kind of thing. And then that moves into preparation where people are kind of bargaining with behavior, like, okay, I won't do that, and then I'll be fine. I won't do that, and I'll be fine. I will start doing this, and then I'll be fine. And then they figure out that some of that works and some of it doesn't. Then in action stage of change, people are doing whatever it takes to make those changes. And then we go into maintenance, which I'm not going to talk about very much. But absolutely. So the maintenance phase is where trauma symptoms can be addressed specifically. So if somebody's able to get clean, stay clean, and then the trauma symptoms are coming up, then that's a good time to address the trauma specifically. So we want to be real, we want to be honest, and have integrity and transparency. So we want to have an understanding of how addiction and recovery and relapse works. And we want to accept, so hold the judgment, we want to accept what's going on with the client and make sure that we are in alignment with their experience. So we're not saying, so you relapsed again. What happened? We're saying, oh my gosh, what was that like to relapse again? And so we kind of, we're client-centered, and we're using motivational interviewing in order to kind of be on the same page as the client. So we've got this goal together. And so let's be curious about, okay, what happened? Is there anything that seems clear, kind of building insight? So that goes along with collaboration with the client. And then assess early attachments. So attachment disruption is going to interfere with people being able to get support in recovery, and kind of what that support looks like, if it's conflictual or avoidant, or just kind of what it looks like. And then explore. So generally speaking, when people are doing their addictive behavior, it helps at first. And so being able to acknowledge that is really validating. And then stabilizing. So this is back to phase 2. So we spend as much time in phase 2 in stabilization as we need to, so that people are going to be able to tolerate the trauma processing. Have to have a positive treatment goal. And we're always looking at target assessment, which is normal for any EMDR therapy. And then we build connections, not only with us as therapists, but also with family, friends, support groups. So here's the stages of change that I was talking about for people who are not familiar with it. Again, pre-contemplation is just leave me alone. I don't want to talk about it. I'm fine. There's ambivalence in contemplation, preparation, start making changes, action. Okay, we're doing this, we'll do whatever it takes. And then maintenance is trying to maintain recovery. So then we've got relapse, which is a thing that happens. So we need to not expect that people are going to get clean and stay clean. So motivational interviewing is a different thing. It's a way to relate to the client. So we're not kind of enabling, but we're expressing empathy. So it may be somebody got a DUI and they're coming in because they're mandated to treatment. So instead of us being, okay, well, you got to get clean now and you have to do this, that, and the other, and the client going, I just want to satisfy the court. So if we're able to join with the client as far as what their goal is. So your goal is to satisfy the court. What do you think they want you to experience in treatment that will satisfy them? So then there's a common goal. So it's not, my job is to get you clean. My job is to help you achieve your goal. So then developing discrepancy. So you want to get out of the court system, but you drove here when your license is suspended. So you're just kind of noticing that discrepancy. Rolling with resistance. I don't want to do this. I don't want to be here. Of course you don't. Of course you don't. Why would you want to be here? Avoid argument. Never helps under any circumstances. Just don't do it. Eliciting self-efficacy. So what is working right now to keep you out of trouble, for example? So that's just a brief overview. Okay, so let's talk about what do we do. So in EMDR, in phase 1, which is the history taking, we want to make sure that we're including specific questions about addictive behavior. We want to know how people have coped, how clients have coped in the life situations that they're in. And we want to be really specific about what people are using, how much and how often. So for example, somebody comes in, you're doing an assessment, you ask if there are any substances that are a problem. They say, no, not really. That's not going to cut it. So what does not really mean? So what you want to do is you want to ask specifically, how often do you drink? If somebody says, oh, I'm just a social drinker, we have to ask what that means. So what do you mean social drinker? And then they may tell you, yeah, I only drink when I'm at the bar with my friends. How often are you at the bar with your friends? Oh, every night after work. Okay, so that's not really the definition of social drinking. It's addictive drinking in a social environment. So we have to figure out what they mean by that. If somebody says that they're using weed to sleep sometimes, then you ask them, so how often are you using weed or THC in order to sleep? If it's every night, then we've got a problem. And also we have to pay attention to that, or benzodiazepines for alcohol use. If it's a daily basis, then it's going to interfere with our EMDR processing. So we have to be aware of that as well. So we need to know these specifics. We're just matter of fact. We're not judging. We're not kind of going, I'm sorry, I have to ask this question. We're just matter of fact. Like, do you have a job? And then, of course, we're including other compulsive behaviors. So we need to ask specifically about those things. Part of what's going to happen is that the shame is so great and feeling misunderstood and alone is going to keep people from just telling us the specifics. even when somebody's coming in for addiction treatment, they don't tell us the whole story. So we have to ask. Okay, so that's the history gathering. Phase 2, the preparation phase, then we provide support and validation. So that's the empathy piece, strengthen positive internal resources. Sometimes people will use slow bilateral stimulation sets, so we can do some visualizations of feeling calm. There's some kind of exercises that we can do with clients, like a calm, peaceful place, or a container to contain all the stuff that feels really distressing and out of control. We can do body relaxation. So all the things that most therapists do all the time. And sometimes if we use like slow bilateral stimulation, then it just strengthens that. So it's not the same thing as processing. Processing is fast. Something about it, the fast BLS helps the brain process. The slow BLS, when we're talking about or thinking about positive internal resources, seems to strengthen. Want to absolutely give them psychoed about addiction, recovery, relapse prevention, of course, trauma, trauma recovery, symptoms. We want to teach skills to manage emotions, triggers, and people, provide resources, relapse prevention planning, encourage and facilitate development of a positive support network. I'm going to show you this this tool that I've developed and used with clients. So this is old school, it's paper. And on one side I have recovery signs, and this is just an example of some recovery signs that a client may notice. And so what we're getting them to do is we're getting them to become aware of the things that are connected. So if I go to a meeting and I get a good night's sleep, then that can correlate with feeling hopeful. And so using this chart, so these are the dates of the month. Using these charts, we can see that there are correlations between like feeling hopeful and believing I can do it, and other things. So the other side of this tool is relapse signs. So I always start with the recovery signs because the shame is so intense that relapse signs are seen as a way to beat yourself up, which is not the point. The point is to become aware. So this is completely an awareness tool. Now I know that there are apps that do this kind of thing. Not really familiar with any of them. I don't want to endorse anything. Okay, so phase 3 is when we're actually triggering something. But we have to identify which part of what they're experiencing we want to trigger. So do we want to get into a trauma memory primarily because it's interfering with addiction recovery? Do we want to treat addiction and trauma concurrently? Or do we need to treat the addictive behavior primarily and then wait to target the trauma when those symptoms become acute? Okay, so I want to talk about some case studies here, because what do we do and how do we know? The answer is it depends. And we need to stay attuned to what's happening with the client. So if they're able to stay clean, but they're having these recurring nightmares and flashbacks, then we're going to want to be really careful about making sure that their recovery is supported, so that when we go into the trauma memories, they're going to be able to stay stable and utilize their recovery tools. Okay. So let's talk about, I don't remember one. Okay, so this is a 30-year-old Native American woman who's attending the Red Road to Recovery program several times a week. She's reconnecting to her Chehalis tribe traditions. She has guilt, shame, and is unsure of herself and her future. She has a job and housing, so that's stable, and she can support herself financially. So if we think about it, this client is in early recovery, been in abstinence for 3 months, is gaining insight, becoming aware, making positive changes, relatively stable. She's learning stress tolerance and emotion regulation skills. She's building a strong support system. She has a history of childhood and adult traumatic experiences, which bother her sometimes with nightmares. So she's not having nightmares every night. She's not having flashbacks. She overreacts in some situations. But basically, she's stable. Okay, here's our question. So Marla, this is the polling question.
Let me launch that.
So,
And then,
go ahead.
oh, I was going to say we did have a few other questions come in after we do this, if you would want me to go over those. Okay.
Yeah, it'll be
That
it.
the poll has launched, so please feel free to fill that out.
So what we're doing is so these are the 3 decisions that most clinicians come up with, like, should we address the trauma now, or addiction now, or both at the same time? So when you think about this particular client, what do you think the best treatment strategy would be? So one of the things to think about is that she's been abstinent for 3 months. So she still has post-acute withdrawal.
Are you able, do you see the results?
No.
Okay. So 83% of people are saying provide addiction and trauma treatment now. 13% have said wait to address trauma until later in recovery, and 3% have said wait to address addictive behavior.
Okay. So as far as I'm concerned, the answer is always, do both at the same time. You can't ignore one or the other. However, we want to make sure that trauma treatment doesn't disrupt the stability of the early recovery. And so if we stay focused on, well, not stay, but are primarily focused on addiction recovery, then hopefully they're not going to be destabilized and relapse. So what will happen, like after post-acute withdrawal stage is over and resolved, which I know comes back and is not that predictable, then there's, you know, the habits change and they're feeling a lot more sure of themselves and have a healthy routine. So we want to make sure that that happens if the trauma symptoms are not too acute. So sometimes when a client is in early recovery, you know, directly addressing trauma is going to destabilize them. So we do not want to do that. So in this situation, the way that I'm thinking, that would destabilize them. Okay, so let's think about another client. Notes. So he is 56 years old. He's a Black man coming back into treatment after a 6-month relapse. So he's been abstinent, he relapsed, then he came back into treatment. He is going to daily AA meetings. He feels confused and dejected. He tells his sister that he's too old to keep trying. He recently went to the ER after punching a wall. So he is gaining insight, but he's emotionally unstable. He's also having nightmares, high anxiety, suicidal ideation, and attempts. Uses self-harm, is unable to stay clean. Recovery is sporadic and reactive, and he has a history of trauma in adulthood. So here's our question again. What do you think the best treatment strategy would be? Waiting to address the trauma until later in recovery, providing concurrent addiction and trauma therapy, primarily focusing on treatment for the trauma. And this is, Marla, this is the poll question again.
Got it. That poll is live, everyone.
Oh, I can't see it.
Okay. 79% of people said, well, change. 78% said provide addiction and trauma treatment now. 14% said wait to address trauma until later in recovery, and 8% said wait to address addictive behavior.
Okay. So what we do want to do, of course, is provide support, education, skills, and resources for all of these clients. And in this case, if you don't treat the trauma, he's not going to be able to stay clean. And if you don't treat the addiction, he's not going to be able to treat the trauma. So this is, again, one of those times where addiction interferes with trauma treatment, trauma interferes with addiction treatment. So they must be addressed at the same time. So the triggers that he's experiencing are most likely trauma and addiction triggers at the same time. So if this person is in residential treatment, and so we can kind of control the environment that he's in, the people that he's around, that kind of thing, then we have that stabilization, we have that container. And then let's say that he's going to psychoeducation groups, and getting support about the addictive experience. And there is EMDR therapy in the residential treatment program. And so that could be a group. You can do group EMDR, which can be very, very effective. You can do individual EMDR therapy and we can target the trigger itself. So, but this man is probably gonna die if he doesn't get treatment for both at the same time. All right. So client 3 is 39 years old. She's a Caucasian, bisexual, cis woman. She's living with her boyfriend and his 10-year-old daughter. She believes that the daughter is disrespectful, which enrages her. She is motivated for change and insight, but she is going off on the daughter on a regular basis. She's been abstinent for 3 years, is very involved in AA. She's a sponsor and doing service work. She's very confused about what is happening to her. So she knows that it's not reasonable, her reaction to the daughter, and she has extensive childhood abuse. So, whole question again.
Okay, that's live, everyone. Okay, it looks like for this one, about 70% of people are saying provide addiction and trauma treatment now, and 30% are saying wait to address addictive behavior.
Okay. So again, we're providing support, education, skills, and resources, or supporting them in getting those things. So my guess is that there is trauma from childhood where the expectation on her was very unreasonable, and there was violence if she didn't meet the adults' expectations. So that's my interpretation of what's going on with her. And so at the same time that I'm supporting her ongoing recovery, I'm also starting to move into processing trauma specifically. So we're identifying kind of an instance where her rage got out of control, and then we're doing the bilateral stimulation and processing and going through on that. Okay, so like I said, processing.
Jeanne, I did want to, so somebody did have a question related to the 3 cases. They said this is appearing to be focused only on those in abstinence-based 12-step recovery modalities, which I have found through experience not to be true all the time. Are we able to ask this question sooner than later?
So yes, that is true. The case studies that I brought up definitely have an element of 12-step recovery and are focused on abstinence. What I can tell you is that, like you said, so part of thinking about it that way is that we're thinking if if somebody uses again, or if they do the behavior again, that's a relapse, which is, you know, a loaded word. So, and if we put it that way, then it does kind of hint at, kind of assumes failure. And so I get your point, definitely. And most of the time, not all the time, but some of the time, abstinence is not their goal. And when I go over the EMDR treatment protocols, I think most of the protocols, abstinence is not the goal. The reduction in symptoms is, and I'm going to have to run through that pretty quickly. So I think I've gone over this already. Any other questions?
A few more had come in. Can you speak to the area between the assessment and starting desensitization stage? If client has extremely elevated scales, anxiety, etc., not specifically training, but your overall thoughts and understanding. My example specific to clients with no prior therapy experience seems scary to know when to move to stage 4.
Yeah, there's for EMDR therapists, this whole thing is really scary. But you know, when you first got trained and you started like triggering people in phase 3, so that you could do the reprocessing, is really scary because you do not want to break clients. And this is the same thing. So in phase 2, we absolutely have to make sure that they're going to be able to stay within the window of tolerance, and that they have skills and tools and support that they're going to be able to use after the session and in between sessions. So one of the scariest things for me, having started out in addiction treatment, it was co-occurring treatment, but it was definitely not trauma focused. Kind of, so I've been in the profession for a very, very long time. And so back when I started, people didn't understand that trauma was an integral part of addiction. And so I kind of figured that out on my own. Like, if we don't address this trauma stuff, people are not going to succeed. And so our goal at that treatment program was abstinence. And in private practice, not so much. So it's really a clinical call as to what you're going to do. But you do want to make sure that they have some solid support that will help them deal with whatever their addiction is, and also get, you know, the education that they need about how addictive processes work, and that they're, you know, stable enough that they can deal with the intensity of the reprocessing. Does the answer that question?
They have not responded, but I think, oh, they said, yes, helpful, nail down stage 2.
Nail down stage 2. Yeah, so phase 2, we're going to spend a lot of time there, especially with addiction treatment. Okay. Was there anything else? Any other questions?
There was one more. Do you have time, or would you like to keep moving? We can save it for the end if there's time.
Let's save it from the end because I want to go over
Okay.
The addiction protocols. Okay, so Addiction protocols can reduce the urges, the obsession, the compulsion, and the shame of addiction. So for EMDR therapists, what about standard protocol? That's my go-to. I learned EMDR therapy before all these protocols were written down. And so I did standard protocol very successfully for many, many years. And so that's my preference, is to use standard protocol that makes sure that we are staying, connected to what's going on with the client. So, don't focus on the script more than you are what's happening with the client as you're going through the EMDR therapy. So there's also some dissociation with addiction. And so what I have found, but I also do parts work and specialize in dissociative disorders, but regardless, what I found is that people who have addiction disorders feel like they have a part that is the addict. And that's normally what they will call it, is the addict. And so addressing that part and validating that that part has a job, which is to keep the person alive by rescuing them from feelings or whatever it is that feels threatening. So that's another aside, and none of these addiction protocols addresses that at all. Okay, so when we're in reprocessing in phase 4, euphoric recall and urges will come up and they will get stronger and stronger and stronger. And if you guys are anything like me, it terrifies me. Because we have always wanted to just avoid those feelings, those intense feelings, because we're absolutely sure, and we've seen that when those triggers in the euphoric recall and urges get so intense that people use. And then that destabilizes everything that's forward. But just like with any kind of process and reprocessing, the urges and the euphoric recall will get more and more intense right before it resolves. So it's the same process. It's kind of our window of tolerance that we have to deal with. Okay. So EMDR and EMDR, which is the national organization, has printed this flyer on acronyms. So DeTur is one of the protocols. Cravings is another. Now, this level of urge, there's several different protocols that kind of address this. So Dr. Jeanne Meyer talks about the level of urge to avoid. And he's talking about avoiding, intense, unbearable feelings. We also use just level of urge, like craving level, as a measurement. So when we're using some of these protocols, instead of asking, how disturbing is this memory, we're asking, how strong is the urge to use? So we use the same kind of 0 to 10, with 0 being, I don't want to use at all, and 10 being, I'm going to walk out of here and use. So that's what we're keeping track of instead of the SUDS when we're using these particular protocols. So feeling state addiction protocol is another one. And then I'm going to show you this palette of EMDR interventions in addiction. So, so this is the palette, and Marla sent that PDF to you, so hopefully that'll be available. So this takes some study, which we don't have time for, but the different protocols can address kind of different things that are going on with the client. So she has broken this down to trauma-focused EMDR and addiction-focused EMDR. I'm not going to go into that much. Okay, so with DeTur, it's desensitization of triggers and urges reprocessing. So again, abstinence is recommended but not required. It does help reduce some withdrawal and anxiety. And we identify and strengthen the internal resources and build coping skills. And then the treatment goal is positive and achievable rather than the absence of a negative behavior. So, for example, abstinence is not the goal. So not doing things that are going to make things worse and are self-destructive. So relapse is reframed as new targets of opportunity. So for example, what happened instead of what's wrong with you? And you're desensitizing triggers in order to reduce the level of urge to use or act out with BLS. So what that means is that the trigger is the target. And this is, all of the addiction protocols are restricted. So we're not going full on into trauma processing. We're kind of staying focused on so for example, with the person who goes into a bar and then, smells the smells and sees people drinking and hears the voices and all the stuff. The level of urge, the trigger may be actually going into the bar. So what was the level of urge before you walked in there? And then that's the target. And then you reprocess that. So the positive feeling state, the assumption is that feeling good is wired to the addictive behavior. So again, abstinence is not the goal. Loss of interest in the behavior is the goal. So the success is no longer feeling euphoria when triggered. So you don't get that euphoric recall, basically. Cravings is sometimes called the addiction memory, which is the memory of the loss of control or cravings and or the memory of use of a specific drug. And the addiction memory will last throughout recovery or abstinence, meaning that you can be abstinent and in some kind of active recovery for years, but that addiction memory is still lurking in the background. Okay, so those are some of the specific addiction protocols. So here we are. We're looking at mistakes that clinicians make. So addiction clinicians will work only on abstinence and relapse prevention, avoid any mention of traumatic experiences, see any medication, including antidepressants, anti-anxiety meds, as a drug, refer client to mental health counseling as a separate modality, assume that relapse is due to a character defect or lack of motivation, become frustrated with the client for not getting it, being a frequent flyer or a retread, and then give up on the client. And then mental health clinicians, we don't ask about addictive behaviors. So in the same way that addiction professionals do not want to talk about trauma because it might be a trigger. Mental health clinicians don't want to talk about addictive behavior because they don't want it to be a trigger, or they don't think it's important. Sometimes they refuse to treat until a client has been absent for a significant amount of time. Assume addictive behavior is only a symptom of underlying issues or trauma. So I want to refer back to the dizzy baby. And as far as I know, there were no underlying issues. She was 6 months old, and she clearly loved being altered. And they refer people to addiction treatment as a separate modality. They underestimate the impact of addiction on therapy. There's over-reliance on mental health medication. Assume the client is treatment resistant or avoidant, and give up. Okay, so best practice as far as I'm concerned: integrate addiction and mental health treatment, have a team approach with coordinated interventions, skill building and education, have training in co-occurring disorders, use individual, family, and group counseling, psychoeducational groups, medication management as necessary. To encourage involvement in support groups, help client understand how to manage all types of triggers, trauma, and addiction, and help the client develop personal relapse prevention, a personal relapse prevention plan that integrates, the addiction symptoms and the mental health symptoms. But you can't separate them out. They're not separate in the client. So we can't separate them out when we're working with somebody. Okay, so that's a whole lot and probably brings up a lot more questions. And so, consult with people who understand co-occurring disorders and co-occurring treatment. Do advanced trainings. If you have not been trained and are thinking about EMDR basic training, highly recommend it. It's a game changer. People will heal, and so the focus changes on from managing symptoms to actually healing, and the symptoms are no longer there. And so, in review, the need for co-occurring treatment is urgent. Trauma and addiction recovery have similarities. There's similarities in addiction and trauma symptoms, triggers, recovery, and relapse prevention. There's three strategies for treating clients with both trauma and addiction. Standard protocol rules. So EMDR standard protocol works. Addiction protocols are tools to focus on specific aspects of addiction. Okay, time for questions.
Okay, Linda asked, is there a way to teach personal EMDR exercises to use when urges are strong and threaten relapse?
Not EMDR specific. So all of the tools that you teach clients to stabilize emotionally and physically and everything are the tools that you use. So like the 5 senses. So grounding in right now, the present. The mindfulness is very helpful. Making sure that people, encouraging people to have support with people who are not engaged in addictive behavior. And emotion regulation, distress tolerance, all those things. Those are all phase 2 preparation for EMDR therapy. You can also add, like one of the stabilization tools that I use the most is the butterfly hug. So it activates the parasympathetic nervous system response and just calms things down. That can be incredibly helpful when the urges get very, very strong, because there's, the urges is an urgency. And so the sympathetic nervous system before somebody uses is activated. And so if we can calm that down, then the urge reduces. Okay.
Someone asked, can you recommend training or learning how to utilize addiction protocols?
So in the bibliography, there are some resources of people who develop these protocols. Also, EMDR.org has trainings that you can utilize. You have to be a member, and the resources that they have are incredible. They have a whole resource kind of section about addiction and EMDR therapy to using the practice, which is very, very helpful. Like with several of these slides with the handouts are in there. So I would use like EMDR approved trainings. Right, I just saw what Susan said. Yes, you have to do the basic training before you can do the advanced trainings. So you can't do EMDR therapy unless you know how to do EMDR therapy. So, basic training, and Andrea has a list of those as well that are ongoing. Some of them are online, some of them are in person. I personally like the in-person ones. I'm assisting in some in-person ones in Oregon. And I love that. I think that works the best for a lot of reasons. Okay.
All right, and then this one came in a little bit ago and it's a bit longer. If the substance isn't being used chaotically and not causing negative experiences in their life, and they aren't using it prior to an EMDR session, I was always taught that substances don't hinder progress with EMDR therapy. What if someone is on a narcotic medication such as Adderall for ADHD or Ritalin or benzos for anxiety, or patients using MOUD, methadone, buprenorphine for their SUD?
Good question. So, as I said before, there are some substances, whether they're prescribed or not, that will slow down EMDR therapy processing. So benzodiazepines, THC, alcohol, methadone, buprenorphine. So it isn't that the reprocessing won't happen, it's just like a lot slower, which personally drives me insane because how fast the reprocessing can happen. And if somebody's using more than they say they are, which, with recreational drugs is almost always the case, then you may be reprocessing and cannot understand why it's not really working the way that you think it should. So then I would start asking more questions. So any kind of opiate is going to slow down processing depending on how high the dose is. It may completely interfere with reprocessing. Yeah. So basically, if the question is, do you have to be abstinent in order for EMDR therapy to work? The answer is no, you don't. Marley, you're muted.
Sorry about that. I said those are all the questions I had come in. If anyone has any last minute ones, please get those in now. Any last minute thoughts, Jeanne?
No, this is the list of references, and it should be available as a PDF. I want to thank you for your attention. And just let you know that I am approved EMDR consultant, so and a substance abuse professional. So if you want to contact me for consultation or EMDR certification, I am available. Here's my contact
Oh,
information.
someone asked if are there any EMDR telehotlines to do emergency services?
No, you can't really do EMDR therapy on an emergency basis. Those are your regular stabilization strategies and hotlines. You can't do EMDR on an emergency basis unless you're in a war zone or immediately following a car accident or trauma or something like that. Then you can do emergency EMDR. Okay, well, thank you very much.
Yes, thank you. If everyone would like to stick around for just a few seconds, I have some last minute housekeeping items just about CEUs. We would like to thank you all again for attending. Thank you, Jeanne, for such a wonderful webinar. We would like to remind you all that a PDF of today's PowerPoint and any other resources, along with the recording of today's presentation, will be uploaded to the webinar library located on iRetta's website soon. I already have the files, so I am going to send an email out to all of our registrants as soon as we log off here. I want to remind you of our evaluation and CEU process. You will receive a follow-up email from us. It will include a link to the evaluation and step-by-step instructions on how to obtain your CEUs. Please note that it will take up to 48 hours for your CEUs to become available because of having to cross-check attendance records with WebEx. We would like to request that you fill out our evaluation. It should take no more than 2 minutes of your time. Again, we want to thank everyone for taking time out of your day to participate. If you have any questions at all, please email us. The email address is info@iretta.org, or you can email me personally at marla@iretta.org. That's MARLA@iretta.org. And with that, I will conclude today's webinar. Thank you so much, and hope you have a great rest of your afternoon or morning if you're joining from the West Coast. Thanks, Jeanne. Bye.